changes, cutaneous ones. The non-specific ones, most of us know, is erythema nodosum or calamities cutis. But the specific ones has various manifestations. They can appear as flat lesions, which are the macular one, or the raised ones, which are papules and plaques. Now the plaques one are the one which have great resemblance to psoriasis and even lichenoid lesions. So there are psoriaciform and lichenoid kind of sarcoidosis as well. Then we have nodular sarcoidosis, which is palpable three-dimensional structure. Subcutaneous nodules is a manifestation of sarcoidosis. We can have ulcerative form of sarcoidosis, dry zoonotic ethiotics form of sarcoidosis, even morphoid or morphia-like sarcoidosis. Sarcoidosis, we usually keep it in differential. This is not something that you can see and pinpoint that this is sarcoidosis. They can usually appear as reddish brown, reddish oilicious, rays of flat veins, mostly on the face. If it's on the face, it's known as mostly as lupus pernio, not necessarily, but can be. These lesions are mostly asymptomatic. When we see sarcoidosis and we suspect that it's sarcoidosis, we definitely look for the systemic involvement as well, like hydrolymphadenopathy, joint changes, any gastrointestinal changes. And when we keep it in our differential along with other, we definitely go for the skin biopsy for histopathology to see non-caseating naked granulomas. Now when we say non-caseating naked granulomas, these are the ones which have epitheloid cells, no caseation, and very sparse lymphocytic periphery border. That differentiates from the rest of the granulomating disorders like skin tuberculosis, which is lupus, because this also comes under the differential of sarcoidosis genes.
Sana has adequately described the variety of opinion sarcoidosis. I would just tell the common scenarios that we see in our routine rheumatological practice. Usually we see the adult patients with cutaneous sarcoidosis, number one. And number two is these patients present to us with a history like in months, a few months, 4 months, 5 months, 6 months. Number 3 point is that they will just feel there are bumps over the face, over the trunk, over the arms. They would just feel something appearing on the face and the trunk and the arms. Because as Dr. Sana described, these are mostly asymptomatic. Patient will not feel itching, patient will not feel pain on these lesions. So this is the scenario, and this is mostly not associated with dyspnea or joint pains. So just bumps. And as we see clinically these lesions, we feel these. As we feel these with the hands, the palms, these are both palpable, that is raised, as well as flat, that is not raised here. The color, and these are plaques, that the size is more than 1 centimeter, and the small lesions, less than 1 centimeter, which we call it as papules. And then we pinch this lesion, some of the lesions, we feel that in the 3 dimensions, and we nodules. Suppose very small, less than 0.5 centimeter areas, papules, plaques, and nodules. And then we see the colors. This is reddish brown, or mildly erythematous lesions. And when we feel it, these are mostly not soft, but rather indurated. We feel the firmness in these lesions. So this is the typical scenario that we see in our OPDs and rheumatological practice. And when we see, and then we come the differential of these lesions, these can't be eczemas, because eczema is always itching. And this is always covered with scaling, aggregation, and clustering. This can't be psoriasis, because psoriasis is covered with silvery scales and also with itching. So the main differential of these three is granulomatous diseases. That is sarcoidosis, granuloma facial, lupus erythematosus, cutaneous tuberculosis, or cutaneous T-cell malignancy is important differential in our scenarios. And then we work for the histopathology and so on.
Thank you, Tim.
Yeah, one more thing about it. When we consider sarcoidosis, we do a bedside test which is diastrophy. And we place a glass slide over the skin layer, and if we observe yellowish brown apple jelly-like hue in it, that also helps in clearing our differential towards sarcoidosis, though the same and this appearance can be present in lupus vulgaris as well, but definitely this is one of the things which helps in pointing towards granulomatous disorder.
Dr. Ahmed, you want to Thank you, Sana. Thank you, Professor Alikrashi. Very enlightening talk and discussion. Yes, we do see patients in our practice with Lofgren syndrome, so rheumatologism with periarthritis. Mostly they are coming to us with bilateral painful ankles, and it's more of a periarthritis than synovitis, and there are painful lesions which you really have to look for because they might not be just bothered about these small nodules. And yes, looking at the chest X-ray will be like the full triad of Lofgren. Generally, it is self-limiting, but yes, few of them may progress to have disease which may require suppression long term. But this dilemma remains actually for the clinicians is that they were being treated as gout. They are being treated as cellulitis because of that reddish hue in the skin and that swelling, which is because of the periarthritis in the low shins and the extremely tender tibia, medial side of the tibia. So that actually mimics like other things as well. And at times, even if it is like asymmetrical, DVT has to be in the differentials for the clinician. But we need to remember that this is something which can happen. It's not that uncommon to see in primary care as well as in rheumatologic practice. I would like to hear from Mason and Dr. Ahmed what their experience with dealing with such acute sarcoidosis.
Thank you very much. Thank you very much, our dermatology colleagues. Very helpful talk. I must admit, being a rheumatologist, we do come across a lot of skin disease, but at the same time, we do require a lot of input from dermatology as well. Regarding particularly sarcoidosis, obviously, from a rheumatologist perspective, we go with our general plan anyway, a history examination, blood test, and try to put everything in the picture. But sometimes it's not possible for us to definitely diagnose that this is sarcoid. So I must say that this overall sarcoid is a systemic disease and does need a holistic approach and MDT most of the time. I just have one point here to ask rheumatology colleagues as well, that because sarcoid is a systemic disease and it's been well known that it can go unnoticed, being asymptomatic in certain number of the patients. Do you come across patients who had skin disease just on the presentation of sarcoidosis where they don't require any treatment and they completely resolve in a certain period of time? Do you have any experience on it? It is important just to know from our perspective as well. Thank you.
I think I can understand if you're asking whether the previous lesion resolves spontaneously.
Yeah, and they go on.
No, I will not see even a single case of cutaneous sarcoidosis which don't require treatment. Because mostly we treat such cases, we initially start, if it is a single lesion or 2-3 lesions, just topical steroids. But if the lesions are more, then you definitely start with oral steroids. But the dose is slow. That is just in adults you start with 20 or 30 milligram per quarter. Although it's tapered very rapidly, Along with these, we mostly give hydroxychloroquine. And the patient is not showing adequate response, or there is a relapse on taking the steroids, and on HCQ, if it is still not being controlled, the lesions are progressively increasing, then we also sometimes give methotrexate in patients with continuous sarcoidosis. So, there is definitely need treatment with topical steroids, oral steroids, short course, along with these immune modulators like hydroxychloroquine or methotrexate. And we have also seen cases which initially present without continuous sarcoidosis, as we regulated by lectures with the chest. Some of the cases do develop pulmonary sarcoidosis later on, or other manifestations like eye involvement, joints involvement. So, as a rheumatologist, we routinely advise these patients, regular follow-up these patients, to pulmonologists, and to rheumatologists whenever they develop joint problems.
Thank you. I'll just request Dr. Tuba for a short presentation regarding our panel discussion. She's a fellow of rheumatology at KEM.